Hello everyone, I am Dr. Priyanka Udawat, consultant at Institute of Digestive and Liver Care, SL Raheja Hospital. Today I am introducing endocytoscope by Olympus. This is H290 EC gastroscope, which I am having in my hands. So this scope has ultra high magnification with 520 times magnification ratio. So this enables us to see pathology as microscopic level. This has a diameter of 9.7 mm and length of 1350 mm. It should be attached to 290 Olympus processor. Colonoscope length is 1665 mm with the diameter of 12.8 mm. And so the endocytoscope, what it does, so we can see the normal view and we can switch from normal view to magnified view with the help of this extra button, which is like an elevator button in ERCP. You can see here. So in this scope, we can switch from the normal view to magnified view with the help of this button, extra button, which is there. You can see it's like an elevator of ERCP scope. So once we do it on the downside, then we see the magnified view. So before magnification, we stain the mucosa with the help of dyes. And what we use is 0.05% crystal violin and 1% methylene blue for staining the superficial mucosal layer. And we have to wait for 1 minute. After that, with the help of objective lens, we focus the area, the stained area, and then with the button, we start magnifying. And then real-time in vivo observation of cells and nuclei are possible with endocytoscopes. So it helps us to evaluate different pathologies at microscopic level during endoscopy itself. It is helpful for the patients who are having positive family history of GI cancers, and this scope will be useful for differentiating different kind of pathologies and to differentiate early cancers.
So we are new to magnification endoscopy. I think last year we started using it. We have done about 140 odd cases. We are learning and we are finding very, very good uses for magnification endoscopy. I think it will be very important for our digestive wellness clinic.
Thank you giving me this big title, Magnification Endoscopy. Are you ready to replace histology? It's a big title for me, but anyway, so let me talk about this issue. And before my talking, so congratulations, your team, and congratulations, Foundation Day today. I'm very great honor to be here. So, yes, I have no disclosure. So this is my background of magnified endoscopy. So my mentor is Professor Kudo. This is taken 5 years ago. But when I was 27 years old, maybe more than 25 years ago, I went to his hospital to learn colonoscopy. 1994. This is me, and this is Professor Kudo. He's very, we are very young at that time. I learned 1 year under him about magnified endoscopy. This is first so electronic magnified endoscopy, so-called 200Z. This is my own magnified endoscopy. When I was 28 years old, I came back to my hometown and I bought my own magnified endoscopy because at that time there is no magnified endoscopy in my university, so that I bought my magnified endoscopy. This is 200Z zoom scope, and this is Professor Kudo's hand stump, and this is real stump, yes. So this is decorate in my hospital. And at that time, I learned Kudo's pit pattern. And then I moved to the National Cancer Center East, 1998. So this is a big year because I met my boss, Dr. Yoshida, and Professor Tajiri as well at that time. And also I met Mr. Gono. He's an engineer of Olympus. And so it started to develop nerve band imaging. And 1998, I investigated special reflectance analysis using spectroscopy. We obtained many spectral analysis using probe type spectroscopy. And then we finally identified some specific lights to highlight the GI cancer. It's 1999 December. And then we finally choose two lights. One is 140 and one is 540 nanometer. At that time, there is no name as this narrowband. But in 2001, we named this narrowband imaging is NBI. So I presented DDW 2001. This is the first report of NBI in 2001. And 2006, I proposed my Sano capillary pattern, as you know. And then 2006, NBI released in the world. I got at that time DDW president and plenary, and this is 2016 picture, the 10th NBI year ceremony held in Kobe. He's Mr. Gono, and he's Professor Tajiri. So let me talk about my presentation. Open question is what for improvement of the optical imaging? I think one is a detection to obtain the minimal leaf change or minimal color change. And so the other is for the characterization. We always analyze the superficial bezel network, and also we assess the mucosal pattern. And so this optical imaging, this is NBI reports published gastroenterology 2016. So if we use a brighter NBI with good Boyle preparation, NBI highlights polyp more than more compared than white light. So 1.62 higher polyp detection rate compared than white light. Now, I think nowadays, so the other optic so imaging, such as BLI or LCI, also showing this improved data. And for the so daily practice during colonoscopy, we face two polyps, and then we have making a decision for the distinction between neoplasia or non-neoplasia, and estimation of the depth of invasion. And I think mostly 95% is a distinction between neoplasia or non-neoplasia, and less than 5% is estimation of depth of invasion. And this is Janet classification reported 2016. This is using a magnified endoscopy because in Japan we commonly use magnified endoscopy, so we need a magnification classification is necessary. And this Janet classification e-learning video is already so published in the digestive endoscopy. So please review this article, video article, please. Sorry. And this is Japan so expert team data, initial data using Janet classification. Study 1 means so distinction between non-neoplasia or neoplasia. As you see, the high confidence rate is more than 80%, and the negative predictive value also more than 90%. So the Janet classification is going well. And the study 2, meaning estimation of depth. Unfortunately, even use Janet classification, the high confidence rate is less than 75, and the overall accuracy is about 80%. So that we Janet team decide so it's not enough. But so that if we want to estimate the depth of invasion, still we apply some chroma endoscopy, and we observe the pit pattern analysis. And I talk about endoscopy. And this is first generation endoscopy. First generation was probe type, and so insert from the biopsy channel. But so many improvements has been done. And this is the latest model, CFH290 ECI. This is we can obtain more than 500 magnification view, and this scope is almost the same as a standard colonoscopy. And pull down this knob, we can obtain continuously so high magnification view, as you see. So this is you can see the almost 520 whole we obtain. And insertion is also same as so standard colonoscopy. I show you one video. This is LST non-granular type using endoscopy. After intracarmin dye with zoom, so we can obtain a very clear surface pattern view, as you see. This is the only intracarmin dye spraying. And after staining using a crystal violet and the methylene blue, you can obtain the living cellular image. This is EC2, Kudo's EC2, so that this lesion diagnosed as tubulovirus adenoma, very clear view, as you see. I show one case. What is your diagnosis? Adenoma or hyperplastic? My first impression, the lesion is very whitey, so that hyperplastic poly. But with NBI, I found there are some bezels here and here, you know. So I observed this area using endoscopy. And center area showing almost issue 1B, meaning a hyperplastic pattern, goblet cell rich and shaggy pit pattern can be seen. And the other part is also, but upper part, I approach, I found a strange feature here. And close up, as you see, this area is a completely different surrounding area. You can see the pseudo stratification like pattern, and you can obtain the tubular, oval, longitudinal future here. So this is diagnosed as EC2, so adenomatous pattern. So that I performed the polypectomy, the part showing tubular adenoma. So we can make this diagnosis very precisely in vivo, real timely. And Professor Kudo and Misawa Sensei and Mori Sensei published many papers regarding endoscopy. Maybe Professor Mori talk later about these findings. So I think I talk about future endoscopic imaging. As you know, this year, new EBIS X1 Olympus CV 1500 released. And now maybe you can use, and we Japanese use. This is including RDI or EDOF or TXI or proven relevant imaging, very brighter and relevant image. I show you some video. This is EBIS X1 using a CFXZ 1200. This is a dichromatic imaging, RDI, highlight the thicker bezel in the deepest tissue. And this is a TXI, highlights a contrast or highlights a color. So we can see very clearly the findings. And also we can obtain the very clear, brighter narrowband imaging. You can obtain the very clear bezels, as you see. I think resolution is much higher than previous EBIS Lucera. And so this is RD compared RDI versus NBI. As you see, TXI highlights not highlight the thicker bezels, but RDI highlights the thicker, deeper bezels. And NBI only highlights the surface. Because RDI using reddish and greener lights, it's penetrate to deeper. But the NBI using blue lights, so it's a penetrate the surface only. It's a reason why you can see that these findings. So I show you one video. This is RDI. This is a white light. Changing RDI, you can obtain the thicker bezels. So this is an injection. We can available injection avoiding thicker bezels. Prevent to bleeding when I use EMR or ESD. Just like this. And also, if the bleeding is occurring, switch to RDI is also very useful to identify the bleeding point. and switch to RGI, the blood cell change to the yellowish color. It's not so stressful, and you can identify the bleeding point very easily, as you see. This is a bleeding point, and coagulation very precisely, and yes, now stop. So RGI is very so useful to prevent so bleeding, or so it's useful to inject. And this scope is CFX newer 1200. The grip is improved because switch can be pressed more easily like this. And also the angulation parts also improved more smoothly. So we can operate more easily up, down, and the left side, left side and right side. And this scope has 3 lights, and so biopsy channel is 3.7 mm in diameter. And this scope is also very obtained very clear image, like this is a high magnification, higher magnification compared than the previous model. We can obtain a 135 magnification with a high resolution. So as you see. So now we have lots of imaging, so PLI, NBI, or endoscopy, confocal and microscopy, or molecular imaging and fluorescence imaging. So I think I would like to answer your question. Magnification endoscopy, are we ready to replace histology? I think, as you know, microscopy, it's meaning a histology, is a cross section. And the pathologist using HE staining. And they diagnose both structure atypia and the cellular atypia. You know, and we endoscopists, we use magnifying endoscopy or endoscopy. It's a horizontal finding, but we can stain. So using angiocalamine or crystal violet, we can obtain a vital staining. And also we can observe the surface pattern and the bezel pattern and the cellular feature using an endoscope. I think, as you see, almost the same. We see the almost the same. So I think with NBI, magnifying endoscopy, endoscopy with NBI, with AI, sorry, maybe my answer, are you ready to replace histology? Maybe I think yes, in the near future. But I think maybe Dr. Mori so talk about this answer more exactly. So thank you for your kindness attention. Anyway, so congratulations, Ideal Care Foundation Day. Thank you very much.
Thank you, Yasu, for that lovely update on magnification NBI and endocytoscopy and your entire journey and role in developing this marvelous technique. I mean, there's no doubt that we are there, almost ready to predict histology, maybe 95% of the time very accurately. I don't think there's too much doubt on it. My only issues are, in a lot of areas, I have sat in a lot of conferences and I've seen the big guns debating about images, people from the East, people from the West, and there's so much of inter-observer variation in these borderline cases, the 2B, 3, that 2B to 3 or 2A to 2B, there's so much of inter-observer variation. When experts have such variable opinions, what happens to the novice endoscopists or the non-experienced endoscopist? Where does he stand? Can we depend on artificial intelligence to raise his standards so that he's almost as good? I think there are a lot of issues about AI as yet. I don't think the world across, whether the professional bodies or the others, have accepted AI because of a lack of robust prospective studies. I think that's a big thing. But ultimately, the big challenge is, okay, we are almost 95, 96% there with magnification and NBI, with the third generation scopes, maybe add a couple of percentage more with the endocytoscopes. But what happens? What is the legal position? Can we justify, say today, that we end up deciding to do a resection because we think it is malignant and we land up with a problem? Are judges willing to accept the role of AI, the role of this kind of advanced imaging in our decision taking in day-to-day practice? I think that's one big step that we need to take. And of course, in India, the issue is going to be the cost. Everything is going to come at a price. From the basic endoscopes to NBI, the price of scopes goes up. When you come to the third generation NBI, the scopes are going to be more expensive. No doubt they're giving more information, but ultimately the payer, whether the institution, whether it's a government or the hospital, they're going to have constraints on buying this equipment. And I think these are going to be the challenges to the Indian gastroenterologist. Yasu?
Yes. Yes.
What are your comments? What do you think?
I'm sorry. I'm sorry. One more question, please.
So basically, what Naresh is saying is, yes, we are almost there, but there are hurdles, especially in India, in terms of costing, because the scopes are expensive, and legality, whether it is legal to accept an optical diagnosis compared to a histological diagnosis. So your views on that?
Okay, so yes, very endocytoscopy and so newer system is very expensive even for Japanese. You know, so I think so. But I think maybe later endoscopy, standard endoscopy resolution is improved, so that standard endoscopy, I think maybe overall accuracy may be improved compared than previous one. So I think year by year we can obtain some good data for the histological or endoscopic assessment.
What is the legal position in Japan on accepting optical biopsy as gold standard?
No, it's not yet. But Mori Sensei, Dr. Mori is maybe applying something using AI.